Good. Thanks very much for the introduction, and I want to thank the AAMDS Foundation for sponsoring this program this weekend, and also want to thank the local organizers, Dr. Tan Travahi and Dr. Pulsifer, for asking me to speak on PNH today. So, and thanks to the audience for taking this time on a Saturday to come out and learn more about PNH and bone marrow failure, MDS. Okay, all right. So my talk today is, of course, on PNH, and this will be divided into these four sections: the pathophysiology of the disease, how we diagnose it, management, and what's on the horizon for treatment of PNH. So we'll start with the pathophysiology, and just to remind you that PNH, although it's classified as a hemolytic anemia, is much more than that. It's actually a disease of the hematopoietic stem progenitor cells. So the abnormality in PNH starts with in the bone marrow with a somatic mutation. That is, this is not a genetic disease, but rather an acquired disease. So the mutation occurs in a progenitor cell or a stem cell or an early progenitor cell. This is, as a result of this, there's a clonal expansion of the mutated cells. This is a clonal disease, but it is not a malignant disease. And typically in patients with PNH, these somatic mutations have occurred in several different stem cells that are then selected based on that, the absence of GPI-anchored proteins. So the somatic mutation affects a gene called PIGA, which is involved in the biosynthesis of the glycosyl phosphatidylinositol anchor, and we'll go into some detail about that shortly. But this, again, typically involves several different stem cells. Now, because of the PIGA mutation, all of the progeny, that is the cells that are derived from the mutant stem or progenitor cell, are deficient in all GPI-anchored proteins. And the converse of that is true as well. That is, all of the GPI-anchored proteins that are normally expressed are deficient in PNH. Okay. Okay, good. All right, so here's the characteristic feature of PNH cells. So they're deficient in so-called GPI or glycosyl phosphatidylinositol anchored proteins. And this is a cartoon that illustrates the difference between GPI-anchored proteins and transmembrane proteins. Is this pointer, is it showing up? I don't see it. Is the pointer, it's not showing up, is it?
It's on the upper screen, if you see it in the upper screen.
Oh, you go up here?
Yeah.
Oh, okay, all right. There are two different screens down here, so I was confused. All right, so this is, this is the, okay. So this is, most proteins in cells have this structure. So there's these are so-called transmembrane proteins. So they have an ectoplasmic domain, and this is the part of the protein that sort of sticks out and is the kind of the business end of the protein. And then this is held in the lipid bilayer of the cell by a short sequence of hydrophobic amino acids. And then these typically have a cytoplasmic tail that oftentimes has some biological activity in and of itself. So the difference is that the GPI anchor proteins are missing this part of the structure of a transmembrane protein, and they're anchored into the cell by this complex structure, glycosyl phosphatidylinositol. And again, they maintain the business end of the protein here, but the anchor is different. And so the PNH defect involves the very first step in the biosynthesis of this anchor, and that's the PIGA protein, which is actually an enzyme, a glycosyl transferase that attaches the amino sugar to the inositol portion of the structure. Okay, all right. So we can summarize the pathophysiology of PNH in a very simple way, even though this is quite a complex process. So this is representative of a normal hematopoietic cell. And of course, they have normal transmembrane proteins. And these are the GPI anchored proteins. This is just illustrating two of the GPI anchored proteins. These are the complement regulatory proteins, CD55 and CD59. So they're linked to the cell surface through this glycosyl phosphatidylinositol moiety. So in PNH, there's a mutation in this gene, PIGA. Again, this is the very first step in the biosynthesis of the GPI anchor. So as a result of that, all of the proteins that would ordinarily be linked to the cell via this mechanism are missing in PNH. And then we can illustrate the genetics of this. PIGA is located on the X chromosome. So in males, of course, have one X chromosome and one Y chromosome. So when this GPI anchor gets mutated, or when PIGA gets mutated in a male, then all of the cells will be affected. The same thing is true in females, although for a different reason. In females, there are two X chromosomes, of course, but in somatic cells, only one of these X chromosomes is active, and so the other is inactive. So when the mutation in PIGA occurs on the active X chromosome, then that would behave just like it would in a male. So you only have to inactivate the PIGA gene on one allele. Okay, so I've talked about the deficiency of GPI anchor proteins and illustrated that with CD59 and CD55. Actually, there are many GPI anchor proteins that are expressed on normal hematopoietic tissues, and this is a partial list. But it turns out that, as far as we know, the only pathophysiology that results from deficiency of GPI anchor proteins involves the complement regulatory proteins. So even though all of these other proteins are missing in PNH, they appear to have no significant clinical complications. It's only the deficiency of the GPI anchored complement regulatory proteins that causes the problem. And so this illustrates how the complement system is involved in PNH. And it's the alternative pathway. So there are three different complement pathways, the classical pathway, the lectin pathway, and the alternative pathway. And it's the alternative pathway of complement that mediates the hemolysis of PNH. And in this illustration here, I show the C3 convertase, and this is a very important amplification part of the complement cascade. And it's controlled by CD55 and also by CD59. The result of the activation of this pathway is the deposition so this is the amplification part of the pathway. So you get a great deal of amplification of deposition of the C3 molecule onto the cell surface that then can go on to form the C5 convertase. And this then leads to formation of the membrane attack complex of complement. This is the part of the complement system that lyses the cell. And so eculizumab, which and its relative ravulizumab, which I know a number of you are being treated with, it blocks the formation of the membrane attack complex. But because it acts upstream in the complement system, this part of the complement cascade is not affected by treatment with eculizumab. There's a new treatment with pegcetacoplan that targets the more earlier part of the complement cascade here at the C3 stage. And I'm going to talk more about those as we go along. So this illustrates what happens in a normal red blood cell. If they have normal amounts of CD55 and CD59, they block any activation of the complement system. And so there's no lysis of the cell. On the other hand, in PNH cells that are missing these complement regulatory proteins, GPI-anchored complement regulatory proteins, there's no control of the alternative pathway of complement. And as a result of that, the cells undergo osmotic lysis as a result of pore formation by the membrane attack complex of complement. And when these cells lyse, they release hemoglobin out into the plasma, as well as LDH, lactate dehydrogenase. And these can become important markers for hemolysis in PNH. So, getting back to the pathophysiology of PNH, I'm going to again remind you that this is a clonal disease, but it is not a malignant disease. So there's clonal expansion of one and usually several hematopoietic stem or progenitor cells that have acquired a somatic mutation in PIG-A. So, what is the basis of clonal selection and clonal expansion in PIG-A mutant hematopoietic stem cells? So this, again, this differs from a malignant disorder because there is no intrinsic proliferative or survival advantage if you have a mutation in PIG-A. So there must be another mechanism for clonal selection and clonal expansion, because the PIG-A mutation in and of itself does not produce a proliferative or survival advantage. So in PNH, the survival advantage is due to properties of the affected stem cell that's related to GPI-anchored proteins that protect them from destruction in the setting of an immune attack on the bone marrow. And it's likely, based on more recent data, that the mechanism involved somehow affects the downregulation of the HLA system. So this hypothesis is indirect. There's strong indirect support for this, and that's based on this observation that PIG-A mutant GPI-anchored hematopoietic stem cells are commonly present in patients with aplastic anemia, which is an immune-mediated bone marrow failure. And I'm going to illustrate this. This is the way I kind of conceptualize this process. In patients with aplastic anemia, as Dr. Tantravahi explained, there's an immune attack on the bone marrow. Now, the PIG-A mutant hematopoietic stem cells escape that immune attack because of deficiency of one or more GPI-anchored proteins. And this results in so-called oligoclonal hematopoiesis. So this is a normal bone marrow. And under the concepts of Darwinian evolution, these GPI-anchored proteins that are illustrated here, these colored cells, are present in the marrow. In all people, normal individuals have GPI-anchored, PIGA mutant cells in the bone marrow, but they're quiescent. They're not really have any real impact on the bone marrow under normal circumstances. But when there's an immune attack on the bone marrow, these normal cells are destroyed, and there's something about the PIGA mutant cells that allows them to escape this immune attack on the bone marrow. So these are selected. Again, this is an example of Darwinian evolution occurring in the bone marrow, where there's a selective or survival advantage based on this mutation. So this is not enough in and of itself to explain PNH, because if these clones had no expansion capacity, then they would remain largely undetectable. So something happens, probably related to stress hematopoiesis, that results in additional expansion of the PIGA clones. So this expansion would depend probably on a number of factors that would include so-called stochastic processes that are part of the intrinsic properties of the stem cell. And then perhaps other somatic mutations occur that allow these clones to expand further. This is what produces the PNH phenotype. These in individual patients, the PIGA mutant cells can account for 90 to greater than 90% of all of the hematopoiesis may be derived from these one of these PNH clones. Okay, so diagnosis of PNH is actually very straightforward, but once you suspect PNH, it's easy to diagnose it, but because it's a heterogeneous disease, it has many different clinical manifestations. And these the clinical manifestations are determined primarily by the percentage of PNH cells, and that has to do with the size of the PNH clone, along with the PNH phenotype, which is the extent to which the GPI-anchored protein or complement regulatory proteins are deficient. So there are two major determinants of the PNH phenotype based on clone size and expression of GPI-anchored proteins. So this, you saw this, if you saw Dr. Tantravayi's talk, you saw this illustrated in these flow cytometry histograms. So this is a normal control. On this axis, we're identifying red blood cells based on expression of this protein called glycophorin. And then on this axis, these are the two GPI-anchored proteins, complement regulatory proteins, CD55 and 59. So here we're looking at red cells, here we're looking at neutrophils. In a normal individual, all of the red cells express the GPI-anchored proteins, and the same is true for neutrophils. So then we have the three classifications of PNH, subclinical PNH, and in this case, the PNH clones is very small and produces only a tiny percentage of abnormal cells. Nonetheless, you can see how clearly different these are in terms of the expression of the GPI-anchored proteins. So even though it's a tiny clone, it's clearly present. And then another category is PNH in the setting of a defined bone marrow failure syndrome. This is particularly aplastic anemia and low-risk MDS. And here the clones are larger, and it's about at 20% or so clone size that you first begin to detect biochemical evidence of PNH based on the hemolytic parameters. So here the clone size is about 20%. Now this is smaller in the red cells because the red cells are being selectively destroyed by the complement system. And this is illustrated in the classic PNH. And here we have a very large PNH clone or clones, and so 96% of the neutrophils are derived from the PNH clones. So here, the 72% versus 92, again, this difference is explained because the PNH red blood cells are being selectively destroyed by complement, whereas the neutrophils survive normally because they have other ways of defending themselves against complement activation. So we base clone size on neutrophils and monocytes. So in addition to the PNH clone size, the other important determinant of the clinical manifestations is the PNH phenotype. And this, the cells are divided into type 1, type 2, and type 3 based on GPI anchor protein expression. Type 1 cells are the residual normal cells, so they're not really PNH cells. These do not have any defect. They were named very early on before we understood the genetic basis of PNH. So it's a little bit of a misnomer to call them PNH1 cells, but they're normal residual cells. Then the type 2 cells are partially deficient in PNH. They're partially deficient in the GPI anchor proteins, and the type 3 cells are completely deficient. And this, I'll show this, well, here's a photograph of my mentor, Dr. Wendell Ross, who made many important contributions to understanding of PNH, but one of them was to define the different PNH phenotypes. And he did that using some very elegant methods that have largely been replaced now by flow cytometry, but at the time were really innovative studies. But here's an example of the phenotypic mosaicism in PNH. So this is the normal control on the bottom, and you can, these are the two GPI anchor proteins. Let's just focus on the right side here you can see that the expression of the CD59 protein, it has a nice Gaussian distribution here and has a very bright expression because the CD59 molecule is fairly dense on the red cell. So this illustrates the two different phenotypes in PNH. Let's look at the left side first. The PNH3 cells are the ones that are totally deficient in GPI anchor proteins. And the PNH2 cells are, in this particular patient, where the dominant clone was PNH2 cells. Now you'll notice that this is a log scale. So even though it looks like there's a great deal of difference between these two, because it's a log scale, this represents about 10% of normal expression. So this, again, this is a normal control, 10 to the third, whereas these are 10 to the second power. And so this tells us something important about PNH, that the clonal selection involves a very profound deficiency of the GPI anchor protein. So this tells us that you have to be somewhere under 10% or so, in order for the clone to be selected by the immune attack on the bone marrow. So this is, as I said, threshold for clonal selection appears to be about 90% GPI anchor protein deficiency. Now, the genetic basis for this is also understood, and that is that if you tease apart all of the different PIGA mutant cells in this particular patient, you can identify at least 4 different genotypes. And the ones that, the genotypes that completely inactivate the PIGA gene result in the PNH3 cells. Whereas if there's partial residual activity, usually due to a missense mutation, then there's some activity left. The PIGA protein has some activity, but it's has about 10% of the normal function. So this leaves us with the PNH2 clones based on partial residual function of PIGA. And these phenotypes are important clinically. And I've illustrated this with these mock histograms here showing the type 3 cells. If they're present in a high number, then these patients will have brisk hemolysis. On the other hand, you can have a large PNH2 clone, and in this case, there'll be very modest hemolysis. And then you can, if you have a small PNH clone with just the type 3 cells, even though they're type 3 cells, because the proportion is small, there'll be very little hemolysis. Okay, so let's move on to the management of PNH. And this starts with a basic evaluation of PNH. And it's really a pretty simple process. Everyone, of course, has flow cytometry. This is the way that we identify the expression of the GPI anchor proteins, and also the way that we determine the clone size and the phenotype. So this is a very important first step in characterizing PNH. Other important aspects are complete blood count. We want to know if other cell lines are affected besides the red cell line. And the retic count is an important parameter for assessing the function of the bone marrow. And then we look for biochemical markers of hemolysis, and the LDH is a very important one. This is particularly important in identifying so-called extravascular hemolysis. The bilirubin is helpful as well, and haptoglobin, but the LDH is the most important one in diagnosing and following PNH. And we determine iron stores as well, because patients at presentation can be deficient in iron because of loss of iron as a result of hemoglobinuria. Bone marrow aspirate and biopsy are important, as well as genetic analysis of the bone marrow cells, because these help us understand if there are processes ongoing in the marrow, such as aplastic anemia or myelodysplastic syndrome. And then once we have this information, we can classify the patients into 3 categories. And the first 2 categories have clinical manifestations as a result of the size of the PNH clone. And the third one is subclinical. So classic PNH is, and we have these parameters that we use as part of the categorization of these of patients. So the rate of hemolysis, and this is based largely on the LDH and patients with classic disease have markedly elevated LDH and oftentimes have episodic macroscopic hemoglobinuria, so actually see the hemoglobin in the urine. The bone marrow, on the other hand, shows that the red cells are increased in production, but otherwise is normal or near normal. And there's a large clone these patients have large PNH clones, usually greater than 50% and oftentimes greater than 90%. And these are the patients who benefit the most from treatment with complement inhibitory therapy. PNH in the setting of another bone marrow failure syndrome, and again, this is usually aplastic anemia or low-grade MDS. The degree of intravascular hemolysis is usually mild compared to the florid hemolysis in classic PNH. And by definition, there's evidence of another defined bone marrow failure syndrome. Typically, the clones here are smaller. They're still greater than 25% because it has to be that high in order to see biochemical evidence of hemolysis. And about 50% of the patients who fall into this category will require some specific therapy for PNH, either any complement therapy or anticoagulation for risk of thrombosis. And then the subclinical patients, there's no biochemical evidence of hemolysis. They only have a detectable PNH clone based on flow cytometry. So by definition, these clones are small. There's a same thing here. You have evidence of a bone marrow failure syndrome. Typically, these clones are very small, oftentimes under 1%. The majority of the patients who fall into this category will have very small PNH clones. And there's no benefit from treatment with any complement therapy. I'm going to, because of time, I'm going to skip over this, but this just has to do with PNH in the setting of another bone marrow failure syndrome. So once we classify these based on that earlier classification that I showed you, we can use this information to develop a treatment plan. And so with subclinical PNH, again, there's no need for any anti-complement therapy. Here the focus is on the underlying bone marrow failure syndrome. Then in patients with PNH and bone marrow failure, again, most of the emphasis here is on treating the bone marrow failure, but patients, again, some patients with this who fall into this category will require some form of PNH therapy, either anti-complement therapy or anticoagulation therapy. And then the classic PNH, this is when patients benefit a great deal from treatment with complement inhibitory therapy. So moving on to the treatment of patients with anti-complement therapy. This is eculizumab, which is a humanized anti-C5 antibody that was the initial treatment for patients with PNH. And these are just some of the interesting biochemical features of this. This is a very cleverly designed antibody. Now, of course, I think many of you know that when you require treatment with eculizumab, you require vaccination with meningococcal antibodies, and oftentimes we also use anti-pneumococcal antibodies and anti-Hib antibodies as vaccination as well. So this requires an initial loading dose and then is infused every 2 weeks continuously. As I state here, this has now largely been replaced by ravulizumab, which is a very similar antibody, although it's had a clever modification that causes the half-life of the antibody to be greatly extended. So now, rather than treating every 8 weeks, you can treat rather than treating every 2 weeks, you can treat every 8 weeks. And coming back to this slide that I showed earlier, this is where eculizumab and ravulizumab act. They block C5 and prevent the membrane attack complex formation, which then prevents this intravascular hemolysis. Now, again, you notice that because of the defect in PNH, there's lack of control of this earlier part of the complement cascade as well. And so this results in opsonization of the red blood cell. So when you think about it, PNH, the extravascular hemolysis of PNH is entirely an iatrogenic process. So you never see this in PNH in patients who are not treated with anti-C5 therapy, because the cells would all be destroyed by the membrane attack complex. But because this is blocked with the anti-complement therapy, now we can see the effects of loss of control of the C3 convertase. Okay, so what does eculizumab, and again, ravulizumab falls into the same category. So what it does, it ameliorates the symptoms associated with chronic intravascular hemolysis. And these are the symptoms that patients recognize. So malaise, lethargy, fatigue, asthenia, which is a kind of a general sense of loss or general loss of well-being, and then dysphagia, which is seen in some patients with fluoride hemolysis, and male impotence can also occur. And treatment with eculizumab can really be transformative in patients who have symptoms related to the intravascular hemolysis. About 65% of patients who were transfusion dependent will become transfusion independent. So there is still about 35% or so of patients who will remain transfusion dependent despite eculizumab or ravulizumab treatment. But even those who remain transfusion dependent, the interval between transfusions will increase. And another very important part of this inhibitory therapy is that it markedly reduces the risk of thrombosis in patients with PNH, which is another very important part of the disease spectrum. What it doesn't do is it doesn't block the extravascular hemolysis that's mediated by C3 opsonization of the red cells. And of course, here you're treating a symptom of the disease, but you're not treating the underlying process. So bone marrow failure, if it's present, will persist while being treated with anti-C5 therapy. The clonal hematopoiesis will continue. The reason that this is very effective therapy for a long period of time is because PNH is not a malignant disease. So just by inhibiting the main complication of PNH, you can make a tremendous difference in the quality of life in patients. And this shows that how the treatment with eculizumab is beneficial over a long period of time. So this is cumulative survival in patients, normal control here, shown in the dotted line, in patients with, these are patients with classical PNH. And you can see that the survival is the same in PNH patients treated with eculizumab as in the age and sex match control. Okay, so other types of treatment in PNH, so stem cell transplant. This is a curative therapy, so you can eradicate the PNH clone by allogeneic hematopoietic stem cell transplant. As opposed to treatment with complement inhibitory therapies, which don't have any effect on the underlying disease. This actually cure the disease. So however, in the era of complement inhibitory therapy, the other reasons for transplant that used to be used, for example, uncontrolled hemolysis or uncontrolled thrombosis, have now been eliminated by the availability of anti-complement therapy. So we're really left at this point with patient preference. PNH is a chronic disease and often affects young adults. So despite effective therapy, quality of life can be compromised by the treatment burden. But because this is a non-malignant disease, enthusiasm for transplant is muted. I think I'll skip breakthrough hemolysis, and we can come back and talk about that when there's a bit more time. I'm trying to leave time at the end for questions, so this is the reason I think maybe just skipping this and moving on to, because I know many of you want to know about what's on the horizon for treatment of PNH. There are patients who have a suboptimal response to eculizumab or revilizumab as a result mainly of extravascular hemolysis. So even though the LDH concentration can return to normal or near normal, patients treated with anti-C5 therapy maintain oftentimes a fairly high degree of reticulocytosis and some degree of anemia. And some, again, may remain transfusion dependent. And so this is due to C3 opsonization of the red cells, which leads to destruction of the red cells by the reticuloendothelial system. So we've kind of covered this before. So I'm going to illustrate here the C3 opsonins that result as a result of activation of the C3 convertase here. So this results in deposition of C3 onto the red cell surface, and it's actually covalently attached to glycophorin, primarily glycophorin A, on the red cell surface. So once this gets attached to the red cell, it very rapidly undergoes degradation by a combination of factor H and factor I. This results in cleavage of the C3 molecule, and then another red cell protein, CR1, results in further cleavage of this, leading to degradation with the C3DG moiety. So this goes all the way down to a very small molecule. But there are receptors for this molecule on reticuloendothelial cells in the spleen and the liver. So this is recognized by those receptors, and those cells are then destroyed in a process that's called extravascular hemolysis. So rather than being destroyed in the circulating blood, these are actually removed from the circulation and destroyed by phagocytic cells. So interestingly, PNH, one of the early characteristic features of PNH was the so-called Coombs negative hemolytic anemia, because the Coombs reagent did not recognize any C3 on the red cells, and that's because all of the cells were being destroyed. So now that the complement inhibitory therapy, the C5 inhibitor development, we do get deposition of these C3 molecules, so now it becomes Coombs positive. But again, this is something that is iatrogenic. So here's, I've illustrated some of the ways in which there's interest in developing inhibitors of the earlier part of the complement system so as to prevent the opsonization process. And one of these drugs, pegcetacoplan, has now been approved. In May of 2021, the FDA approved Empaveli, or pegcetacoplan, and it works by inhibiting the activity of C3. Now, C3 is not an enzyme. It actually is the binding site for the enzymatic component of the C3 convertase, here factor B. But by reducing the amount of this protein, you go on to limit formation of the C3 convertase. There are also factor D inhibitor that's in clinical trials, and there's now a second generation factor D inhibitor that's being tested as monotherapy. Recent interest in this protein that is an inhibitor of factor B. And this is interesting, well, because this is an oral inhibitor of factor B, so it can be taken twice a day, and in initial studies appears to be very effective in blocking formation of the C3 convertase. And of course, if you block that activity, then you'll block the downstream effect, so you won't form the membrane attack complex either. And so iptacopan has been studied in patients with PNH and compared to patients with C5 inhibitor therapy, and shows a very promising efficacy and safety profile so far, but still has not been approved for clinical use. And also there's interest in blocking the lectin pathway of complement, or at least one of the enzymes involved in the lectin pathway, MAS3, that appears to be a factor D activator, and also piperidin here, which is a stabilizer, although this is not being developed very much at this time. So those are the new treatments that are being developed. And again, there's great interest in developing inhibitors that will prevent the extravascular hemolysis as well as the intravascular hemolysis. So thank you for listening, and I guess it's afternoon, so anyway, I hope you've learned something from this. Thanks. I've left a little time for questions.
Yeah, we still have time. Thank you so much, Dr. Parker. So now we're going to take some of our questions from online. Our first question that came in is, I've had PNH symptoms since 2006 and have extravascular hemolysis. I have been on all 3 treatments, and all of them started to become less effective over time. Would there be some explanation for this?
Well, I'm sorry, the patient said she or he had extravascular hemolysis?
Yes.
Uh-huh. And so, again, the C5 inhibitors will block the intravascular hemolysis. I'm presuming the patient has been on Empaveli as well, and I'm not sure what the third one is. I guess was on some sort of clinical trial. So one of the important things to understand about PNH is that it's a disease of the bone marrow. And so all patients have a defect in the bone marrow that causes anemia and oftentimes leukopenia and thrombocytopenia, although the degree varies. So what I found in my experience with patients who are so-called refractory to anti-complement therapy is that the problem is not due to complement-mediated hemolysis, either intravascular or extravascular, but rather due to the bone marrow and limitations on erythropoiesis. So typically when I get asked about this, this is the first thing that I look for, is that how well is the bone marrow producing red blood cells. So a good indicator of that is the reticulocyte count. So I would suggest that the most likely explanation for the persistent anemia is not due to complement-mediated destruction, but rather due to ineffective erythropoiesis.
Thank you, Dr. Parker. And our second question, which will be our last question, is, do you think danicopan and iptacopan hold promise for patients who have only had partial response to the 3 drugs currently on the market?
Oh, okay, so the 3 drugs, so eculizumab, ravulizumab, and I would say yes. I think all of these drugs are very good that are available. So the inhibition of intravascular hemolysis is very well controlled by eculizumab and ravulizumab, and extravascular hemolysis is very well controlled by pegcetacoplan. So the other drugs that are coming along, so the factor B inhibitor, factor D inhibitors, would they add anything to the inhibitory process? I would say probably not. The difference is, they're oral versus subcutaneous infusion, and the other C5 inhibitors, again, they're highly effective in inhibiting C5, but they're not going to be much different in that capacity than the available C5 inhibitors, eculizumab and ravulizumab. So again, I don't think that, because we have very effective mechanisms for blocking both the C3 convertase and the C5 convertase. So these other drugs that do the same thing but work at a different site or bind to a different part of the C5 molecule, I think are unlikely to make that much difference for an individual patient, because the other drugs work so well.
Thank you so much, Dr. Parker, for sharing your time and expertise with us.